Let's move to the clinical presentation. First, of course, is looking to the risk factors, which have been shown to increase the risk of serious disease. And this includes older age, diabetes, heart disease and hypertension, smoking, interestingly, blood type, which we'll discuss, obesity, and some genetic factors. But also, according to a large study in England of over 17 million individuals, being poor, being non-white, or being male also increased your risk. And also proposed is that individuals with A blood types were 33% more likely to test positive than other blood types, and those with type O blood were less likely to test positive than other blood groups. Well, why? A person's blood type indicates what kind of antigens cover the surfaces of their blood cells, and these antigens produce certain antibodies, so there may be a predisposition due to a blood type. Obviously, there is a difference in clinical presentation dependent on staging. First, though, is an investigation into comorbidities that increase risk of serious consequences, including hypertension, diabetes, obesity, cardiovascular risk factors, COPD, renal disease, and being immunocompromised, but then also looking for the signs of infection, like hypotension, tachycardia, tachypnea, and fever, and then specifically for the lungs, bronchial breath sounds, wheezes, bronchi, and rales. A paradoxical presentation unique to COVID-19 is what is being termed silent hypoxia. So patients who have been sick for days enter the hospital alert and coherent even though their chest x-rays demonstrate significant involvement and their O2 saturation is around 90% or lower. If a patient's O2 saturation is less than 92%, they're admitted. If their exertional O2 saturation is between 93 to 96%, the patient is sent home to monitor with a pulse oximeter. In the hospital, they run, of course, an arterial blood gas, looking for respiratory alkalosis or acidosis depending on the progression. Other labs, of course, focus on several things: cardiac involvement, predisposition to clotting or evidence of clots, markers of generalized inflammation, and blood cultures for superinfections of fungus or bacteria common with COVID-19. Of course, the fear is the progression to acute respiratory syndrome, which is diffuse alveolar capillary and epithelial damage. The integrity between the alveolar endothelium and connected epithelium is compromised. Damage is caused by neutrophil enzyme release, leading to destruction by oxidative and enzyme degradation, and a characteristic histological finding is a hyaline membrane lining of the alveoli called hyaline membrane disease. We'll now move on to COVID-19 testing. There are three types. There's genetic, which is testing for the viral RNA, and then antibody and antigen testing. Early testing in the U.S. was done by a faulty CDC test, while other countries used testing that had already been developed and established as accurate. Those countries then seemed to have a time advantage over the U.S. A compressed development process, where normally it takes years, had to be developed within months, and this led to inadequate testing of the tests. Now there are hundreds of tests available or in development. There are three approaches, again: genetic, also called molecular testing, polymerase chain reaction tests, immunoassay or antibody testing, and antigen testing. Most common is the polymerase chain reaction, or PCR, which has been around since 1985. It requires that the genetic sequence for the virus be established. China sequenced SARS-CoV-2 on January 12, 2020, which allowed overnight development and application of the PCR approach. But although it could be developed within days, it's more than the test creation. It's the scale of production, which is difficult to do quickly. You have to develop supply chains and then scale up and ramp up the process quickly. Currently, there's a problem in the supply chains for swabs, chemicals, and the expensive sophisticated machinery to read and interpret the results. Most are familiar with the infamous nasopharyngeal swab test. This is a PCR-based test. First, they isolate the nucleic acid, then they use reverse transcription PCR to amplify the DNA. The process is to use the reverse transcriptase enzyme to convert RNA to DNA, which is called complementary DNA. They then make lots of DNA, and they use primers and nucleotides plus enzymes. The primers will color the DNA, so if COVID RNA is present, it will become apparent. Many companies have the test, including major producers like Roche and Abbott and the CDC. This is a test for symptomatic individuals. The Abbott M2000 testing platform and other platforms test hundreds per day, but there are also miniaturized testing solutions available. The miniaturized Abbott testing unit uses the direct placement of the swab into the unit, a response within 5 to 13 minutes. Some suggest, though, that the accuracy may be as low as 48%. So it's not enough to do PCR only due to low sensitivity. The gold standard is considered serology or antibody testing plus PCR, which increases the sensitivity to 99%. In addition, it's important to know if it isn't COVID, what is it? So respiratory viral panels that include swabs and sputum check for multiple viruses in an attempt to rule out other causes. Serology testing is based on a timed immune response. IgM indicates active infection. IgG testing is for antibodies that are produced later, which indicates a past infection. And it may take up to a week for IgM to be positive. The testing window then affects response. So although if tested too early may not have the IgM, and given IgM shows up in a week, because it tapers off and IgG may not be high enough, it may miss detection. Some individuals don't produce enough antibodies, so they test false negative. These are better for population studies to see how many individuals were infected, not as a screen for returning to work. There are rapid IgG-IgM lateral flow assays. The advantage is the results are produced within 15 minutes. The blood is placed on a test strip, put in a buffer, and a lateral flow runs through the nitrocellulose membrane and is picked up by the capture antibodies. Blood is tested on a strip with IgG, IgM, and a control antibody. The control has to be positive for the test to be valid. A negative test result for COVID is a positive for control only. If you have control plus IgM, it indicates an active infection, and if you have control plus IgG, it indicates a past infection. Another approach is the ELISA. This is enzyme-linked immunosorbent assay. The results are available within 1 to 3 hours. The goal is to react to the S protein. If it binds, they add in an enzyme-linked antibody, which binds to that portion, becomes activated, and then chromogen is added. Chromogen is then broken down to produce color, and this is read by a spectrophotometer. The brighter the color, the higher the concentration. And then the most recent are antigen tests. But first you have to capture the COVID from a throat swab similar to a rapid strep test, and then you have to have the right patient population to gather the antigen. The virus is then given to animals to develop antibodies because this is what goes on the test strip. There are very few out there. One that was given approval is Sophia. This is a test machine. So you take a stick with antibodies swabbed from the throat of the patient and then placed directly into the Sophia testing apparatus. Positive tests are accurate, but negative tests can't rule this out. Symptomatic patients are tested with either RT-PCR or antigen tests, but those who are asymptomatic but may have been infected are tested with lateral flow or ELISA testing based on time, at least a couple of weeks. And again, having antibodies does not guarantee immunity. Now let's move on to treatment. Obviously, emergent treatment in a hospital includes monitoring, support, and treatment with various agents and ventilation when necessary. Other approaches are being proposed which mainly repurpose medications used for viral or parasitic diseases. Another approach is passive antibody therapy, aka convalescent plasma therapy, and this uses the blood from a recovered patient. It's purified and given to individuals to passively convey the immune response or antibodies from the donor to the recipient. One treatment would be to develop monoclonal antibodies to bind to the S protein to block entry into human cells. One potential target is the transmembrane receptor. Camostat mesylate inhibits transmembrane receptors, so might be partially affected. Hesperidin is a naturally occurring bioflavonoid which binds to the ACE2 receptor, making it unavailable to the virus, but this is yet to be tested. Also proposed is injection of soluble recombinant ACE2 for binding to virus receptors. Ribosomes process viral RNA strands and produce viral RNA-dependent RNA polymerase driving RNA replication. So remdesivir is a nucleotide analog, very similar to adenine. It takes the place of real adenine, therefore blocking RNA polymerase and continued lengthening and completion of the RNA chain. Remdesivir is given IV. And of course, the noteworthy hydroxychloroquine. Several potential mechanisms. Antivirals such as chloroquine increase pH or alkalinize the endosomes, preventing fusion to lysosomes, and in lysosomes inhibits protease enzymes necessary for viral construction. It's a zinc ionophore which facilitates zinc entry into cells, which inhibits RNA-dependent RNA polymerases, blocking construction of new viral RNA. And also getting attention is vitamin D. Low levels are found in the chronically ill and seniors. Authors suggest that, quote, the weak response of the innate immune system in the elderly may increase viral load, while a shortage in memory B cells leads to misfiring and overactivation of the adaptive immune system by producing a high level of cytokines or a cytokine storm. Vitamin D may suppress cytokine production by simultaneously boosting the innate immune system and avoiding the overreaction of the adaptive immune system to immediately respond to viral load. Other proposed actions of vitamin D and vitamin D production are that all cells have vitamin D receptors, including macrophages and helper T cells. There are vitamin D receptors in the respiratory tree, in particular the sinonasal epithelium, and these will activate vitamin D. And also upregulation of cathelicidin, an antimicrobial protein made by humans, which has an antiviral, antifungal, and antibacterial property. And finally, vaccines. For a vaccine to be produced, not only will the FDA testing for safety and effectiveness need to occur in a compressed time period, literally months versus years, the production chain must be developed and ready to produce tens of millions of doses. In fact, over a decade ago, the government invested millions in 4 facilities that could rapidly make vaccines and other medicines if America were struck by a pandemic or a biological attack of terrorism. 2 of the sites are not yet playing a role, and 2 will only participate in small-scale testing of potential coronavirus vaccines. Vaccines are based on a wide range of approaches, including messenger RNA, DNA, nanoparticles, subunits, synthetic peptides, and virus-like particles, just to name a few. Well, whatever the approach to the SARS-CoV-2 vaccine, it's intended to elicit an immune response to the spike protein. As such, administration of a successful SARS-CoV-2 vaccine will include anti-spike IgG and IgM antibody responses to confer protection. However, serologically speaking, vaccine-induced antibodies may be indistinguishable from natural infection. And of course, the usual concerns. Even if the vaccine is made available, the fear of mandatory vaccination and identification of those who are not vaccinated, the safety of the vaccine, and of course, its degree of effectiveness. One concern is called enhanced immune response or pathogenic priming. This has been found in vaccines that were used in humans without testing for the reaction of exposure of vaccinated animals to the wild virus, leading to an initial benefit, but ultimately in some individuals a more severe disease that in some cases caused death. Often pointed to is the pathogenic priming with a dengue vaccine. But again, this is perspective. More than 40% of the world's population is at risk of dengue. Each year, 390 million dengue infections occur around the world. Of these, about 500,000 cases develop the severe version of this, which results in about 25,000 deaths annually worldwide. In the Philippines, several hundred children were made sick by the vaccine, and it was discovered that the pharmaceutical company knew of this possibility, which raises concerns. For those concerned about requiring vaccination, it's the lack of proper safety testing, and their fears are implanted chips to track everyone, and something referred to as a quantum dot tattoo for monitoring who is vaccinated versus those who have not been vaccinated. Much will change and quickly, but hopefully this presentation provides a general overview of many of the concepts and considerations. This pandemic is a perfect example of the conflicts of thought when public health takes a broader approach to protection, which then clashes with, in particular, U.S. citizens' beliefs that they are entitled to do what they individually feel is appropriate without consideration of the consequences outside of their immediate friends and families. We're all in a grand experiment, and whether the virus dies out, as some hope, or resurges, either on its own or due to the result of returning too quickly to population contact, time will ultimately reveal the answers.